Greetings, everyone. Hi, I'm Dr. Krishna Priya, orthodontist associated with school to help you prepare for your NEET exam, MDS 2023 in orthodontics department. So today we'll be seeing about etiology and diagnosis of malocclusion. Let's get into the topic. And if you have any doubts, kindly put up in the comment section so I can address it at the end of the session. So let's begin today's session. So the first question will be normal nasolabial angle. So what do you mean by nasolabial angle? The term has it, right? So the angle which is shown in this picture, especially the one which is connecting the upper lip to the base of the nose, that is SN point, and also when it connects to the tangent of the lower part of the nose. So this gives us the nasolabial angle. So this nasolabial angle is pretty constant because once the nasolabial angle increases or decreases, it will give us a value so that with that in mind, we can even plan the treatment plan. For example, if at all the patient's nasolabial angle is acute, okay, that means that the upper lip is actually coming forward, which is because of the fact that the patient's tooth is proclined, right? Or else, if the nasolabial angle is more obtuse, that means the maxilla is actually behind. So this actually gives us a relationship between the tooth and the profile, hard tissue and the soft tissue of the patient. So this plays a very major role in deciding the treatment plan. Generally, men will have 90 to 95 and female will have 95 to 105. This is the normal range. So here the normal range is closer to 110, so the answer would be that. Usually nasolabial angle is a very important factor in determining extraction patterns for patients. Answer is B. So, with this information in hand, we can also judge whether, with a given nasolabial angle, we can classify the patient's malocclusion. Like he or she can be a class 2 if the nasolabial angle is acute because of the proclined upper incisor. Also, the patient may have a convex profile which determines class 2. If it is an obtuse angle, which means that the upper incisors are retroclined or positioned, the maxilla is positioned behind. So that may be a class 3. So it will give a rough estimate of what malocclusion the patient is. Coming to the next question. In a patient with the competent lips together at rest, the lip line is opposite the tips of upper incisor. The lip line is then described as. So we've already discussed about consonant smile arcs, right? So the smile arc is associated with, we've discussed what is a smile arc. It is the lower portion of the upper incisor with the upper portion of the lower lip. That is the consonant smile arc, and we discuss whether it is a consonant or non-consonant of flat. Similarly, there is something called lip line. So this mainly depends on the upper lip. How the upper lip has a correlation with the upper incisor. So here, if the upper lip line is actually very close to the tips of the upper incisor, then it means that the patient has a low lip line in associated with this condition. It is not a medium one because in medium it is associated closely with the gingival, and in the high lip line it is associated with the upper gingiva completely. So it will be a lower lip line case for this. That is, the upper lip's position with respect to the upper incisors will give the lip line, whereas the smile arc is usually associated with the lower lip with the upper central. Um, so you should not get confused between lip line and the smile arc. And also in lip line we have high and low based on the position of the upper lip. And in low lip line, which are the conditions which is associated with low lip line would be excessive vertical growth of the maxilla. In turn, when the maxilla is actually growing much, what will happen? It will lead to a short or retrusive upper lip, and therefore it may also result in a changing of the lip line associated with a particular patient. So a low lip line also can have a functional and aesthetic implications. So functionally, because of the low lip line, the patient's ability to speak properly may also differ. So, in summary, what they are about to say is that the lip line has an effect on a patient both functionally and aesthetically, and thereby it is carefully associated before proceeding with the treatment plan. What is a lip step? So today we'll be going to see about a lot of different terminologies and its association with the diagnosis and treatment planning. So what is a lip step? So it's given by Corcus, and in this horizontal lip step analysis, basically it is of three types. The first one will be a positive lip step, wherein the lower lip is present in forward relation to the upper one. And the next one is the normal lip step, wherein the lower is slightly behind the upper lip. And the third one would be a marked negative lip step, wherein the lower lip will be markedly behind the upper lip position, exactly which symbolizes a convex class 2 scenario. So, whereas this will be expressed in a class 3 condition, wherein the patient will be having a mandibular prognathism, because of which the lip would be forwardly positioned. So, class 3 may be because of a lot of reasons, one of them being a prominent mandible, because of which they may have a positive lip step. But here, the question is negative lip step, and it is mostly associated with the class 2 condition. Answer would be class 2. Yes. So this lip step also has an association with the profile of the patient. So positive lip step will always lead to a concave profile symbolizing class 3, and marked negative lip step would give rise to a convex profile symbolizing a class 2. So usually with lip steps you can easily identify. So we've looked about lip lines, smile arcs, and also the lip step is being discussed today. So coming to the facial measurement procedures. So the ratio of the middle third height to the lower third face height is taken. So what would be the ratio here? So the question itself has answer. Okay, they've classified the face symmetrically into three parts: upper third, middle third, and the lower third. So usually the ratio between all each third would be 1:1, right? Because they've equally divided the face into three parts, and we are comparing one part to the other part. It should be in a similar ratio. So the answer here would be 1:1. Because with this question we can also see into the important facts of what anatomical point is used for dividing the face into thirds. So the trichion to glabella is given here, right? So the trichion to glabella is the upper facial height. Glabella to the subnasal, that is the lowest point of the nose, considered as the mid facial height. From the subnasal to the menton, it is considered as the lower facial height. So these are the ways in which the face is divided into three parts, the vertical measurements. And again, the lower facial height is divided into two parts, meaning the upper facial height till this point, stomion, and then the lower two-thirds would be the lower part of the lower facial height, okay, which will be discussing later. So the lower facial height alone is again divided into the ratio of 1:2, wherein the subnasal to the stomion would be the one part, and from the stomion to the menton would be the two-third of the lower facial height. Okay? So the answer here will be, since middle and lower third are divided symmetrically into three parts, thereby the ratio would be 1:2. Discussed here. So what is the clinical significance? We'll go to the picture again. So the clinical significance here is, see, whenever there is retrusion of maxilla, it can be very significantly seen in the middle third. Whenever there is a retrusion of a mandible or a protrusion of mandible, it can be identified in the lower facial height. So in order to identify which part of the face is affected, this measurements will be helpful, and also it will guide us in the associated anatomical region. The clinical significance of the middle third would be mid-face retrusion, that is maxillary retrusion, which may also be because of sometimes protruded maxilla can also be a scenario in this clinical condition associated with the middle part of the face, and also sometimes long nose or broad nose in which the patient may need a rhinoplasty data will be associated with this middle face. Where in lower face, as I've already mentioned about the mandibular prognathism or retrognathism can be identified. Those are the clinical condition associated with the lower part of the face. So facial height is measured from. So we were talking about the measurements in terms of third divisions. Okay? Now we are talking about the total facial height from where it is calculated. So it is basically calculated from the nasion, this point to menton. Okay? This is what it is calculated as. So as I already said, right, the lower part of the face is again divided into two equal parts. So the first part would be it considered as the upper lip length. Okay, this is the upper lip length. Let me mark it for you. It's from the stomion to the subnasal, and the lower lip length would be from the stomion again to the menton. This will be considered as the lower part of the lower facial height. Okay, so it is divided into 1/3 and the 2/3. So here the facial height is measured from nasion to menton. So we've already seen how it has been classified into different thirds and how the lower facial height is divided into upper lip length and lower lip length. Right? So in case of asymmetrical condition, we can immediately identify which part is actually deviated and from which region we have to consider the deviation. So next question, the normal edge and centroid relationship. So what is edge and what is centroid? So the upper incisor value is given as the centroid here and the lower incisor is the edge. So what is the normal value? The upper incisor and the lower incisor. So edge and centroid are in one plane. That is one option. Edge is in front of the centroid, edge is behind the centroid, none of the above. So usually what will happen, the edge is in front of the centroid. That will be the normal edge and centroid relationship as you see in this picture. Normal edge and centroid would be where the position of the initiated tooth will be present. Okay, that is called as the centroid in upper incisor and also the lower incisor. So here the answer would be edge is in the front of the centroid. So now we'll discuss in detail. The normal edge and centroid relationship. The incisal edge of upper incisor is located in the front of the centroid. This indicates that the upper incisor are positioned slightly forward in relation to the rest of the cranial base. So basically, this edge and centroid relationship is depending upon the upper incisor and also the cranial base. So whenever it is present in forward to the centroid, then it means its relation to the cranial base is also like that. So the correct answer would be edge is in the front of centroid as it describes the normal relationship between the incisal edge and the centroid point. So it may also implicate if it is behind the centroid, then it means that the maxilla as such is retruded, or it may be because of the horizontal growth pattern of the patient. On the other hand, if the edge is positioned significantly in front of centroid, then it may also indicate a protruded maxilla. So basically, the edge signifies here the upper incisors, lower incisal edge. That is what is signified as edge. And centroid is the central position of the maxilla. So whenever the incisor position is far before the centroid, it depends protruded maxilla, or when it is so much behind, it is a retruded maxilla. But generally, the edge should be present just before the centroid. That is an ideal position. Here they are comparing the central incisal edge to the cranial base. And also, they are connecting it to the growth pattern. Okay, so we'll discuss that later. So growth pattern, there are basically three types of growth pattern. One is the normal one, that is average growth pattern, and the one is vertical growth pattern and horizontal growth pattern. In horizontal growth pattern, basically it is denoted by the mandibular angle. We've discussed earlier, right, in cephalomatics, the mandibular plane angle. What is a mandibular plane angle? It is generally, see, this is the gonion, right? So from gonion to menton, you draw a line. Okay, or else the basic step will be from this point to the inner ear point, right? That is considered as the Frankfurt line. So the Frankfurt line is taken like this, and the mandibular plane, so the tangent to the lower border of the mandible is taken whenever they meet at the occiput. So now you take two scales and you just keep it like this. If they meet at the occiput, then it is a normal growth pattern. If they meet before the occiput, if they meet before the ear here, that means that the lower jaw is so much vertical growth is there, so which denotes that it is a vertical growth pattern. What if the mandible is so prognatic and it's like forward, the angle, the tangent is like more like this, right? So that means that it is a horizontal growth pattern, because these two lines, if the mandible is in a horizontal growth pattern, it will be flat. So these two lines will be meeting like beyond the occiput. So that is called a horizontal growth pattern. Before the occiput will be vertical growth pattern. At the occiput will be normal growth pattern. So this is how you decide the growth pattern in the diagnosis and the treatment planning scenario. So we were discussing about the centroid relation, right? The position of the maxillary incisors with respect to the cranial base. So with that, they're also getting information about the growth pattern of the patient. Okay, this is the whole scenario. Now let's move to the next question. Doctoral equation is used in. So what is actually doctoral equation? So he identifies that whenever there is a mallocclusion, there is a cause behind it, and he finds out the etiology of a particular problem. So here the answer would be assessing the timing and site of act of etiological factors of mallocclusion. See, this is from the doctoral classifying etiology of malocclusion in the journal. So what he has given is that causes act at times on the tissues and producing the result, which may lead to the malocclusions, or which may lead to the it can be prenatal or postnatal. Okay, some it can be predisposing also, like genetic condition can also be there. But he strongly believes that causes, they act at times, okay, on the tissues, maxilla or mandibular, whatever it is, and therefore produce result which may lead to malocclusion. So the answer to this particular question is B, assessing the timing and site of the act of etiological factors of the malocclusion. That is a doctoral equation. It's a formula which is used to estimate the timing and the site of factors. So, what are all the factors involved in the malocclusion? And it is also an important tool because we identify the cause. Only then, if we break the cause, we break the habit, then we can correct the malocclusion. Right. Malocclusion can lead to which of the following? So, the questions after that will be like direct questions. So, we can directly look into the answer. It is just single point of line. Malocclusion can lead to which of the following? Abnormal muscle function? Yes. When the malocclusion is like class 3, we intently we push the lower jaw forward, right? So it will in turn change the profile of the face. Increase caries? Yes. Sometimes when there is an slanting lateral, we may have developed a caries in the adjacent condition. Facial asymmetry? Definitely yes. If there is a unilateral canine impaction, obviously the bite is going to get changed, so there may be a facial asymmetry. So the answer is all of the above. So this is a condition wherein the patient has facial asymmetry and it got corrected after he did orthodontic treatment. So even habits influence malocclusion, like thumb sucking, tongue twisting, and therefore it influences all the muscle, soft tissue, bone, everything. So malocclusion is really an important cause, and if you identify the cause, correct it, then it can be treated. So here malocclusion actually does everything. Class 3 malocclusion is found in all of the following except. So, okay, we were talking more about class 2 in our previous sessions, but class 3 generally is actually genetic. So, you can always identify a genetic pattern and predisposition in class 3. So generally in cleft palate patients, right? So cleft palate is usually occurring in the maxilla. So they may present with a retruded maxilla or improper development of maxilla. So thereby their mandible is not affected. So mandible will grow in a normal manner or even sometimes will be prognatic. But the maxillary growth and development will be poor and thereby resulting in a class 3 malocclusion condition. Achondroplasia is also a class 3 malocclusion condition, and Down syndrome patients also develop class 3 because of the constant usually Down syndrome patients, they have large and large tongue. So because of the tongue position and the tongue posture, the mandible grows forwardly and the maxilla is not growing as much as the mandible. So all these three conditions present with class 3 except Curie-Robinson syndrome. Curie-Robinson syndrome is a typical presentation of a class 2. So it is actually a triad of factors. One is loss of ptosis, that is, since the tongue is present backward, there is no room of growth for the mandible to occur. And also, they have underdevelopment of the jaw called the micrognathia. And the third factor is the airway obstruction. So, because of the poorly developed mandible and also the backward positioning of the tongue, the airway will get collapsed and the airway will get obstructed. So, all these conditions show class 2 condition, right? So, Curie-Robinson syndrome is associated with the class 2, and the remaining 3 will be associated with the class 3. Super. Yeah, Down syndrome is a genetic disorder and caused by the presence of an extra chromosome. So class 2 relation malocclusion is founded. So the first option is mandibulofacial dysostosis, craniofacial dysostosis, achondroplasia, and Down syndrome. Just now we discussed that Down syndrome and achondroplasia is associated with a class 3 condition. Craniofacial dysostosis is also associated with the class 3 condition. The only thing which is associated with the class 2 is mandibulofacial dysostosis because this it says the word mandible in it. So the mandibular growth and development is severely affected because of which a class 2 relation is formed. So below I've given a picture which clearly represents the mandibulofacial dysostosis. That is, yeah. So it is also called as Stretcher-Collins syndrome. It affects the development of the bones in the face and also the skull. So underdevelopment of the cheekbones will be there. There will be a small jaw and also a cleft palate. But it is usually contribute to a class 2 malocclusion. That is, the upper tooth is actually protruded forward, whereas the lower tooth will be backward, presenting a convex type of face. Okay. So, Urey Robinson syndrome, mandibulofacial dysostosis, or else stretcher curling syndrome, it is all associated with the class 2. Whereas achondroplasia, cleft lip or cleft palate, it is associated with the class 3. Okay. And Down syndrome. Done. Hemifacial microsomia. So this is also a condition which is associated with the class 2 because the patient presents with the convex feature as you can see in this picture. Okay, so obviously this may be a case of mandibular retrognathism. So you can even note the following syndromes that I'm saying to class 2 so that whenever you see a question, you need not spend much time as it to it to identify whether it is a class 2 or class 3. So some things are just fact. You have to understand them and then read it out. So kindly make a note of what are the symptoms I'm saying which comes under class 2 and which is class 3. Hemifacial microsomia comes under class 2 because of the mandibular retrognathism. So basically it is abnormal development of the first and second branchial arches during the embryonic development, and it affects ear, eye, mandible, soft tissue of the face also. So the affected side of the face may be smaller mandible, retrusive chin. It can also be unilateral or bilateral. So unilateral thing means that there will be a facial asymmetry as well. The affected side will be presenting with the abnormality as compared to the normal side of the face. So this can result in mandibular retrognathism or posteriorly positioned lower jaw on the affected side. So the treatment mainly depends on the severity of the condition and surgical intervention is a must. And also sometimes they use prosthetic devices in order to augment the soft tissue of the patient and also to improve the face function and aesthetics. Acromegaly is associated with. Generally, acromegaly means the growth hormone is increased in that patient, or they always present with a gigantism. So all their maxillary and mandibular feature will be big. So it usually is associated with the class 3 malnutrition because they have a prominent chin and prominent jaw. They have strong features because their growth hormone is high, their bone development, everything will be large, and therefore you can like associate your you can remember like this. Acromegaly means something like giant, so they'll have giant jaws and thereby class 3 malnutrition. Okay, I think it'll be easier if you remember like that. Yeah. Characterized by lower jaw that protrudes forward beyond the upper jaw and thereby creating an underbite. Class 3 malnutrition can also be caused by genetic factors, which I've already discussed, but acromegaly means class 3. Binder's syndrome. So, what is Binder's syndrome? Okay, can you see in this picture what is actually affected? The patient's nasal bone development is poor, maxillary bone development is also poor, right? So, Binder's syndrome is usually the combination of nasomaxillary complex, which whose development is at fault here. So, it is usually associated with a maxillonasal dysplasia. Okay, let's find out what is actually scissor bite. Okay, scissor bite is a condition wherein the maxillary, if this is the maxilla, it completely overlaps the mandible. That you can only see the buccal aspect of the maxillary molars will be completely covering the lower molars. That is called a scissor bite. Entire dentition. An open bite you would already know, like the upper incisal edge and lower incisal edge will have a minimum of 2 to 3 mm between them without any contact. Class 2, you know, it is associated with the mandibular retrusion position. Okay, so the answer would be maxillonasal dysplasia. That is the improper development of the nasomaxillary complex, as you've seen in this picture. Yeah, and this condition is already associated with the class 3. Why? Because only the nasomaxillary is a problem. The mandible is actually proper and it is forwardly positioned. So it will invariably be associated with the class 3 condition. But it is only because of the improper development of the nasomaxillary complex. And treatment actually involves surgery and also to correct the skeletal discrepancy between them and achieve the functional and the aesthetic correction. Okay, moving on. A retained lower deciduous incisor will usually. So, what do you mean by a retained lower deciduous incisor? So, it should actually fall by the age of 6 years. But if it is not falling at the age of 6 years, then the permanent teeth cannot come into its position, right? So, either it should come in a forward direction, labially, or lingually. So, only answer to the question is two times. On either labially or lingually. Usually, what happens is that the retained lower deciduous incisor will deflect the permanent teeth labially. Okay, just remember this. It will be opposite for the upper. Okay? But for lower, usually the lower incisor, if it is deciduous, it will push the permanent incisor to go more labially towards them. And let's see why. Because a retained tooth will act as an obstruction to the permanent tooth. So it will push the position of the tooth bud of the permanent tooth in a labial manner, and thereby it comes out labial, causing crowding and malocclusion. So therefore, early detection is very important in preventing this. The most common local cause of malocclusion. So the important aspect here is local cause. Presence of supernumerary teeth, premature loss of primary teeth, delayed eruption of the permanent teeth, caries lesion on the primary teeth. So if you want to find out the most common local cause associated with it, it will definitely be premature loss of primary teeth. Why? What happens? So in this picture you can see proper crowding, right? What has happened here? The second premolar is actually out of touch. Why? Because there may be an early loss of the primary second molar here. So what happened? There was a mesial migration of the permanent molar to the deciduous tooth position. So there was no space for the permanent premolar to erupt in its position. Therefore, it was pushed palatally. Usually, premolars are pushed palatally. Lower incisors, permanent incisors are pushed labially. So each tooth has its own um, route in which it comes from its bud position to the occlusal position. Okay, imagine that and don't answer labially for all the questions. It differs from tooth to tooth. So since the most common cause is only because of premature loss of primary teeth. Okay? Yeah. So the eruption of the permanent teeth may also be affected, and there may be a mesial drift which will be the responsible for 90% of the malocclusion, because of which there will be loss of arch length, arch space, and we have to intervene it properly by providing space maintenance or space management, space regaining procedures, which we also discussed in the previous session. So after doing that, we have to create enough space for the permanent tooth and then bring the permanent tooth to its position. Premature exfoliation of the primary canines indicate. So we must first understand the age at which primary canine exfoliates and at what age the permanent canine comes into action. So what will happen if it actually exfoliates before the eruption of canine? Usually the maxillary canine is the last permanent tooth to come into the occlusion, like before the second molar. So it will definitely create an arch length deficiency. Skeletal malocclusion, I don't know. Arch length excess is definitely not an option here, none of the above. The answer would be arch length deficiency. If that is gone, then obviously the primary molar will try to move forward, right? And thereby the space is lost, and canine requires a lot of space. So it will be an arch length deficiency. Sometimes you have to think straight, like in a common sense manner, to answer a lot of questions pertaining to it. But in order to answer these questions, you should know the eruption sequence of primary tooth and also the permanent tooth. So here the early detection and management is necessary for the primary premature exfoliation of the primary canine before the eruption of the permanent canine. Okay, moving on to the next question. Most commonly retained tooth in a deciduous dentition. So see the key word in the question is deciduous dentition. So what will be the retained tooth? So maxillary lateral, mandibular second molars, mandibular lateral, and maxillary first molars. Usually mandibular second molars. Why? Because critically it is the most retained tooth, and it is good that it is retained because till the permanent second molar comes into its position, and also the primary deciduous molars occupy a lot of space when compared to the permanent premolar. So this space can also be used for the correction of a local crowding which is present in the anterior region, called as the leeway space. So most commonly retained tooth here, it is actually a fact. So it's called mandibular second molars. Yes. So this failure of mandibular second molar to exfoliate can result in an impaction of the permanent mandibular premolar, leading to the localized crowding and also the malocclusion. So coming to the next question, radiograph of a 5-year-old child shows an erupting permanent first molar erupting mesially, resulting in the resorption of roots of the primary second molar. Actually, at 5-year-old, the permanent molar. Okay, this is the permanent molar. Okay, so this should actually erupt like this. What happens? It is actually erupting mesially, the position of the primary second molar. So it is actually mesially drifting. So what will happen, why it is happening, and how it is happening? That is the question. So it's not ankylosis. Ankylosis is something wherein the roots of the tooth is completely associated with the bone and it is not moving. And it is not internal resorption because nothing is said about resorption here. Okay, it is wrong. It's not premature eruption because it is proper age for the tooth to erupt also. It's only 5 years, so the proper eruption age is around 6, so it is common. So it's called ectopic eruption because it is not erupting in its particular segment. It is not erupting vertically up, but instead it is going mesially and pushing into the position of the primary second deciduous molar, which has to be present till the age of 12 years for the permanent premolars to come into its position. So it is actually called ectopic eruption. Whenever the tooth is not erupting in its particular area, but instead erupting in the forward or backward direction, it's called as ectopic eruption. So it can lead to the displacement or malpositioning of the tooth, causing various types of malocclusion. It is often because of lack of space in the dental arch. And treatment usually includes the extraction of the particular teeth, or if that teeth is very important permanent condition, then we have to align it. Coming to the next question, abnormal thick labial frenum results in. So you know labial frenum, right? So this is present here in this. It is thick and it is abnormal. So what happens? It will try to drift the maxillary incisor apart from each other, causing a midline diastema. That's a very common question. Yeah, the answer. So the frenum, what it does, it just pulls the gingival margin and thereby creating an opening. The fibers will just pull it. Therefore, it creates an opening and drifts the maxillary incisor apart. So this, because of this frenum, it is directly creating a midline diastema. The next question: the treatment of diastema because of thick labial frenum is done. So the question is when it is done. The timing is actually important. So now I've shown you how it is done. So basically, it is performed with the help of scalpel. But generally, actually, the frenectomy is performed only after the maxillary incisors are aligned. Why? Because when we are aligning it, we are actually compressing the fibers here, okay, and thereby it may lead to a scar tissue formation. So after cutting it entirely, the scar tissue by itself acts as a retention and prevents the disorganization or the movement of maxillary incisors away from each other. So generally, midline diastemas like frenectomies are generally 90% of the time it is preferred to be done after the orthodontic alignment of the incisors. And also, you all know about the ugly duckling stage, right? Because at the age of 9, when the canine erupts, okay, for imagine, so this is the maxillary incisors, this is the maxillary incisor, lateral incisor, okay. In ugly duckling stage, usually it is seen with the midline diastema here. So when the canine erupts into the occlusion like this, it will push the lateral incisors and central incisors in a mesial direction, which may resolve this midline diastema. So usually the frenectomy or whatever treatment that we are doing is pushed after the eruption of canine, because canine has an innate ability to push the central incisors and lateral incisors in a mesial direction, because the canine erupting it will have an effect on the root positioning of the lateral incisors. So when it has a root position, it just moves like this. So we have to wait till the eruption of canine before proceeding to it because of this reason. After the eruption of the canine will be the right answer. Diastema is often the result of what? So diastema may be an important one, may be the result of an abnormal labial frenum position and also the thickening of the frenum. But also it may be a result of a habit. Okay. Usually, can you see the tongue here? What happens? The tongue has an abnormal amount of force. So how much ever you push your tooth along with the tongue, it will cause a proclination of the tongue along with spacing between them. So thereby tongue thrusting is actually one of the major reasons behind diastema. So in patients with generalized spacing, right, we generally give appliance called tongue spikes, which is either given as a removable appliance or we just place some spikes behind the upper incisor tooth, so that we are training the tongue not to push the incisors forward, and that way when it stops pushing, we don't remove the entire spike, or we don't remove the entire crib like thing at a single time. We remove one at a time, so that we are very sure that the tongue is trained to be inside the oral cavity and not pushing against the incisor. Because when the habit again persists, then it will again lead back to a generalized spacing. So retainers is must and long term for these kind of patients who have space because of a habit. First, we need to break the habit and then proceed with the treatment. An 8-year-old patient has a good occlusion with full teeth present at the age. One of the central incisors is severely rotated with a large midline diastema. So in this question, we understand that the occlusion is perfect and all the permanent teeth has erupted. That is good. But there is no space. Why? Because of an extra tooth. Can you see this condition? And they've also said only one central incisor is severely rotated. That means the position, that is the area required for this central incisor, is being used by the supernumerary tooth. So the answer is very simple. It is presence of supernumerary tooth, and mesiodens is very common. So that would be an answer for this question. The supernumerary tooth, which is present between the central incisor, is called as a mesiodens. It has a separate terminology to it, and usually it will provide the rotation of a particular tooth. Only one tooth associated with that, because it is occupying the space of a particular tooth, and the midline will be shifted in these patients. And usually the removal of supernumerary tooth and correcting using orthodontic treatment will be a treatment for this kind of malocclusion. A crowded and irregular arrangement of mandibular anterior tooth due to the lack of space is generally referred to as. So can you see here? All the crown has tilted towards the same direction. It is crowded and there is not a proper arrangement of a anterior tooth. And this is actually because of lack of space. And this particular uh, turning off the crown of mandibular incisors in a single direction. Can you appreciate a single direction here? It is called as imbrication. Yeah, so we'll see what is imbrication. Overlapping of crowded arrangement of the teeth. It is overlapping one behind the other. So it's most commonly seen in the mandibular anterior teeth, but it can also occur in the maxillary anterior region. It is because of some aesthetic concern, and also sometimes food can be locked into there, which may lead to caries in a long run, and also difficult in maintaining the oral hygiene. So sometimes we use proximal stripping or extraction of only one tooth to create this base, or we proceed with veneers for this kind of patients. Imbrication or lower incisor crowning mainly is a result of arch length to size discrepancy, because can you see here? So the arch length actually is actually very less, and there is a discrepancy between the tooth size and arch length. Okay, so whenever the tooth size is more than the arch length, then it may lead to crowding. But whenever the arch length is more than the tooth size, it may lead to spacing. It should be in a proper ratio with each other. So usually imbrication or lower incisor crowding occurs only when the tooth size is more when compared to the arch length. And therefore, the answer to this question will be arch length or tooth size discrepancy. Tooth in the mandibular arch which is most likely to be displaced due to the arch size discrepancy. Usually it is second premolar, because it is the last tooth to come into the oral cavity. In upper it will be maxillary canine, and lower it will be a premolar only, because canine comes as soon as the after the lateral incisor before the first premolar. So since the question here is mandibular, the last permanent tooth straight up into the oral cavity will be an answer which is second premolar before the second molar. Yes, because of inadequate space and mainly because of the mesial drift of the permanent molar and also the premature loss of the deciduous second molar. Okay, so these more will be the most common cause of malocclusion. The last primary tooth to be replaced by a permanent tooth is usually a maxillary canine, because it's not mandibular second molar or maxillary canine will be the last primary tooth to be replaced by the permanent tooth. Yes. So the mandibular canine usually erupts before the maxillary canine, and the eruption of the permanent teeth is a gradual process, and it occurs with different age groups. Okay, but the average would be the same. And if we detect any abnormality, it's very good to consider it early and take a radiograph to find out the exact position and what age they'll erupt into the oral cavity, because we can otherwise intervene and provide a space maintainer or a space deviator if needed. In case of maxillary canine impaction, true is more commonly right than left, more commonly buccal than palatal, unilateral than bilateral, male or female. So the answer is it's actually commonly in unilateral than bilateral. So you should actually study a bit about maxillary canine impaction, because it is very, very common. And it's usually from 0.9 to 2.8 percentage prevalence. It's commonly unilateral when compared to bilateral, and it's more common in female than male in a ratio of 3:2. And in location also, it is more commonly in palatal. Palatal canine impactions are very much common when compared to buccal impactions. So yeah, so what were given in that was actually wrong, except for the unilateral is more than the bilateral. It needs orthodontic intervention to correct the maxillary infections. Anterior open bite associated with the class 1 relation is generally due to. So you know what an anterior open bite is. Okay? It usually occurs because of a habit, and mainly thumb sucking habit, because we are creating a space in upper and lower incisors. Therefore, the answer is thumb sucking. It will lead to a narrow constriction of the upper arch, which we discussed earlier during the habit discussion. So thumb sucking produces open bite. That was answer to the very straightforward question. Upper tooth natia means what? So it also refers to an open bite. This is also a very direct question. So the open bite, which may actually be caused because of thumb sucking or tongue thrusting and skeletal abnormality, and the treatment would be orthodontic therapy, surgical, or even a combination of both. And upper tooth natia is generally known as open bite. Lisping. So what is lisping? Lisping is actually a speech disorder wherein the patient cannot make certain sounds like yes, and thereby produce, which may lead them to make certain errors when it comes to a speech associated condition. So lisping is a terminology associated with the speech dysfunction by a patient. And why speech dysfunction occurs? Only when they cannot pronounce certain words, and which is commonly associated with the open bite. Because when their tongue is touching the central incisor, it cannot produce the word. So sometimes it comes out of it as a different consonant. So lisping is generally 90% of the time it is associated only with an anterior open bite. Yeah. Lingually locked of permanent left central incisor in otherwise normal occlusion. Everything is normal. There is a lingually locking of the lateral incisor. So what has happened? Prolonged retention of primary right central, premature extraction of the primary maxilla. So the answer would be prolonged retention, because only when a certain tooth is retained there, the similar, that is the successor of the particular tooth, will be locked inside. So as we were discussing, right, for lower incisor, it was pushing the permanent tooth in a labial direction. But upper incisor, it is occurring in the lingual direction. So each tooth has a specific pattern in which it erupts. So don't confuse it. See, the primary incisors are actually coming lingually to the primary tooth. Permanent is coming lingually to the primary tooth, and that was because of the prolonged retention of the primary. And this may also lead to a crossbite. Okay? A localized gingival recession between the two teeth in an otherwise healthy. So since so the key factor in this question is a 7-year-old child. Okay, so only central incisors and lateral may have come for this patient. The localized part. So usually it may be associated with a habit because it is a child. Otherwise, a gingival recession is a condition which usually occurs in an adult. So since it's a localized one and the patient is only 7, it is usually associated with a habit. So the habit here, so the answer would be the abnormal oral habit here. Yes. So usually, the habit will be thumb sucking for this patient. Why? Let's examine. It can also be thumb sucking or lip biting or tongue thrusting only in that certain region. So irritation of a particular soft tissue may even lead to a localized gingival recession of the particular tooth. Chronic gingivitis may be another one of the reason for gingival recession in a kid, or else sometimes a bacterial infection causes inflammation of the gum tissue, leading to bleeding, swelling, and the recession. However, chronic gingivitis is generalized one. The key factor here is a localized gingival recession. So it usually it's associated with a habit. Whereas chronic gingivitis or ANAG is an acute necrotizing ulcerative gingivitis. It is a very chronic condition which is generalized. It is not localized. So since the key factor here is localized, it is commonly associated with a habit. Localized gingival recession in the region of mandibular incisor due to. So I'll be showing you a picture. Yes. See, the answer, the localized gingiva, okay, it is the abnormal frenal attachment is actually pulling the gingival margin below. So the answer to this is abnormal frenal attachment, lower mandibular incisor. So whenever you have an incisor in word in the question and also a localized gingival recession, it may be the, you need not think about a habit here. Okay, maybe the primary thinking you'll get is a habit, but since incisor and gingival recession is here, you should also think about the frenal. So abnormal frenal attachment is the answer here. Yeah, the frenum pull is more common in the mandibular anterior than in the maxillary anterior region. Other causes of localized gingival recession would be traumatic tooth brushing, or traumatic occlusion, or even gingival injury. Okay, yeah. A clinical examination of a 15-year-old girl reveals only permanent central incisors, permanent canines, and primary canines in the anterior to the premolar. So the most probable habit is probable causes. So they are telling us it's a 15-year-old girl. Permanent central incisors have come, permanent canines have come, but still she has a primary canine anterior to the premolar. So what may be the cause of it? Since it's 15 and already she's past the age of the growth of the tooth, there are two reasons why the permanent tooth is not coming. Either there is a prolonged retention, okay, and even in such a scenario, the permanent tooth should either either palatally or buccally to the initial position, or the tooth is actually missing. So only when a permanent tooth is present over the primary tooth, right? Because of its force, it's erupting into the occlusal cavity. There may be resorption of the primary tooth, and eventually it will follow. What if the permanent tooth is not itself there? So there won't be any force acting on the primary tooth, and no resorption would be there. So I think in this condition, the answer would be congenitally missing permanent lateral incisor, since already the canines have erupted. Okay, only the lateral is not erupted on one side. So answer, yes, the answer is congenitally missing. incisor. So always you should not thinking in the aspect of okay, she's a kid, so the habit will be there, or okay, which part it is associated. No, you should always think about what are all the values given in the question. So why they have given this point? Generally, they won't give some random facts in the question. So whatever it is in the question, it will have an effect on the answer. So think why they've given permanent canines have erupted. Usually laterals should come before canine. So since lateral is not come, why it has not come? Actually, it is a case of prolonged retention. Why? It's not resorption is not occurring in it because there is no permanent successor. So the thinking process should be in this direction. Which one of the following has maximum familial tendency? So generally, if this question comes, class 3 would be the first thing coming to your mind. But here the class 3 is not an option. So protruded maxillary incisors, open bite, deep bite, upper and lower cross bite. So protruded maxillary incisors won't be familial tendency kind of thing, but deep bite is. The deep bite is generally associated with the familial tendency. So the picture here represents a deep bite. Yeah. So highest the familial tendency among the molluclution with genetic factors playing a significant role in the development. So 80% of familial tendency is associated with the deep bite prevalence among individuals, and a timely intervention may actually save the patient from a lot of further complications, but orthodontic treatment is generally involved in the correction of the deep bite. A single individual malpose posterior teeth may cause all of the following except there is a single malpose tooth and it's given posterior tooth. What can it cause? So only when the posterior tooth or in cusp fossa or embrasure relationship with each other, okay, then the occlusion will be set, or else the occlusion is disturbed. So they have said only a single individual, and that is also malpose. It will give rise to a lot of conditions, but what it will not give rise to is the question. Uh, Traumatic occlusion, deviated path of closure, close bite, pain, and the movement in the malpose tooth. So the answer would be close bite because obviously there will be a traumatic occlusion. Okay, so a cusp and fossa embrasure, as I've already mentioned, right? So the tooth are in contact with each other. Whenever either one tooth is not in contact, then it will create an occlusal interference, because of which none of the posterior tooth or anterior tooth could contact with the lower one. Okay, this occlusal interference itself will tell us which tooth is at fault, and therefore it will obviously lead to an open bite and not closed bite. But it will definitely give a traumatic occlusion. There will be a deviated path of closure. The patient can't close like this. The patient has to go like this and then close like this. And there will also be pain and movement because repeatedly we are concentrating only on a particular tooth on closing. Therefore, the answer will be closed bite. Yeah. Following are the essential diagnostic criteria according to Grieber. So, case history, facial photograph, periapical X-rays, and lateral cephalogram. So, as I've already mentioned, the case history is very important because that gives a genuine idea of what the patient is and how the patient has developed a particular condition. Facial photograph is essential for us to examine the patient even if the patient is not present. That is very essential. Periapical X-rays shows us for the fact that whether the permanent tooth is coming into that position or whether the tooth is so curiously involved that it cannot be moved as such, or whether there is any cyst in a particular tooth, which is to be examined. Not periapical radiographs are not taken for all the tooth, only to the questionable tooth which requires further help. Lateral cephalogram is actually not an essential diagnostic criteria, it is a supplemental one. Why? Because uh, without lateral cephalogram, we can definitely come into a diagnosis and a treatment planning. Lateral cephalogram just confirms our values with certain cephalometric parameters. So always don't think lateral cephalogram as an essential one. Study model CAR, that was essential, but not lateral cephalogram. Yeah. Poor man's cephalometry is. So these are all the terminology. So usually you understand with it. Poor man's cephalometry is nothing but photographic analysis. Here no cephalometrics or radiograph is essential here. This poor man's cephalometry is nothing but photographic analysis. Yeah, it involves taking standardized facial intraoral photographs and analyzing them to assess the patient's skeletal and dental relationship. So, like just we were looking at about a lip step and lip contour and finding out whether the patient is a class 2 grower or class 3 grower, or finding out the growth pattern of the particular patient. Right? So, these are all the information that we derive from a photograph. So, 4 months cephalometry is nothing but a photographic analysis. Yeah. While diagnosis an orthodontic case, 3/4 lateral view photograph is taken in order to view all of the following except. So a case is taken and 3/4 lateral view photograph is taken. They're asking us which is not getting evaluated here. Relation of the jaws, lip incompetency, profile, mandibular asymmetry, 1/3 middle face asymmetry. So the answer is mandibular asymmetry. So when you want to see asymmetry, you take front photographs. You have to assess from the midline how much the other part is deviated. And in an oblique view, like in a 3/4 view, you can only see about the upper and lower jaw relations, okay, and whether the lip is competent, because we can ask the patient to smile or close their lips and we can identify whether the lips are competent or not. We can also check the profile, but we can't analyze the symmetry because we can't see both sides, right? So the obvious answer to this question is mandibular asymmetry cannot be diagnosed from a 3/4 lateral view, but it can be diagnosed from a frontal view. Okay, so I think we've come to the end of today's session. We'll be continuing from this question tomorrow, right? So if you have any questions regarding the diagnosis and treatment planning today, definitely let me know. I'll help you in answering few of them. Yes. So we've covered diagnosis and treatment planning half, and tomorrow we'll be completing it. And then, okay. So tomorrow's session will be again about diagnosis and treatment planning, where we'll be discussing more about cephalometrics. Okay, see you tomorrow. Bye.